recent in our series of Axiom Town Halls, where we will be discussing key developments in breast and gynecological tumors from last week's ESMO. My name is Ann Cherry with Axiom Healthcare Strategies, and I'm delighted to be joined this morning by Dr. Hope Rugo, an investigator and breast cancer clinician with the Helen Diller Family Comprehensive Cancer Center at UCSF, as well as Dr. Michael Buehrer, the director of the Winthrop P. Rockefeller Cancer Institute at University of Arkansas for Medical Sciences. So, Dr. Rugo, Dr. Buehrer, thank you so much for joining us this morning. Before we dive into the exciting results, I would like to provide a quick overview of what the next hour will hold. So we'll start off with Dr. Rugo in breast cancer, where we'll look at the evolving role of checkpoint inhibitors, ADCs, and CDK4/6 inhibitors. We'll have a few minutes to discuss any questions coming from our town hall participants. So those of you in the audience, please feel free to send those questions through using the Q&A feature at the bottom of your screen. And then we'll move on to gynecological tumors, where we'll start in ovarian, transition over to cervical, then wrap up with a few emerging agents in platinum-resistant disease and a Q&A session with Dr. Buehrer. So with that, I will turn things over to Dr. Rugo to discuss the exciting updates in breast.
Thank you very much. Really appreciate that, Anne. And we're excited to talk to you today about some of the really, I think, practice-changing and intriguing developments that were seen and presented at ESMO this year. So first, I'm not sure there's a cursor over the slide, so I'm just gonna, if somebody can move the cursor, great. First, we're gonna talk about immunotherapy. And I think there was a summary at some point about the particular topics that we were discussing, but I don't see it here. So I'll just run through that here. For early stage breast cancer, we saw immunotherapy trial Impassion 31 as neoadjuvant therapy with atezolizumab. For metastatic triple negative breast cancer, there was actually a really fascinating series of studies, an update on Impassion 130, which of course led to approval of atezolizumab in the first line treatment of metastatic triple negative breast cancer, but then an interesting study with different results, Impassion 131, with a different chemotherapy backbone. And then we saw the practice changing results from the ASCENT trial with sacituzumab govitecan. Then there was two different talks and a really excellent discussion by George Sledge discussing the use of CDK4/6 inhibitors in early stage breast cancer in Monarch E and then the Palace trial, and we'll talk about those two trials as well. Next slide. So we'll start with a neoadjuvant trial in Impassion 31. This trial randomized 333 women who had early stage triple negative breast cancers of 2 centimeters, greater than 2 centimeters, with or without positive nodes and a known PD-L1 status to receive a backbone of nab-paclitaxel at 125 milligrams per meter squared weekly for 12 weeks, followed by doxorubicin and cyclophosphamide with either atezolizumab or placebo. After surgery, atezolizumab or observation was continued to complete 1 year of treatment. The co-primary endpoints were pathologic complete response, either in the intent to treat population or in the PD-L1 positive population. Remember that PD-L1 testing for atezolizumab uses a different antibody and is based on percentage in immune cells alone compared to the testing for PD-L1 in patients receiving pembrolizumab, where it includes both tumor and immune cells and creates a ratio with a different antibody. Secondary endpoints included the usual suspects, including overall survival and disease-free survival, although this trial is not powered to look at event-free or disease-free survival with 333 patients. Because you're continuing the atezolizumab or observation, not a placebo after surgery, they may have some power to look at that endpoint. Next slide. So this was, of course, a multi-center trial, randomized phase 3, and here you can see the endpoint showing a remarkable and statistically significant improvement in pathologic complete response rate. That is no invasive disease in breast and axillary node, and the IS just means in situ disease can be there, 41.1 to 57.6%, a difference of 16.5%, and a p-value of 0.0044. And then you can see the forest plot here looking to see whether or not there's a subgroup of patients who might have benefited more or less. It's encouraging to see that all of the diamonds line up to the right, suggesting that atezolizumab was better. And when you look at the stage of patients, you can see that stage 2 and 3 relatively similar, and importantly, no difference based on PD-L1 positivity, which is what we saw also in Keynote 522. Next slide. Next slide. And here you can see the secondary endpoint data. Because this trial is early, there really aren't enough events good for our patients. You can see for event-free survival events, there's only 10 and 22, 10 and 13 for disease-free survival, and less than 10 for overall survival. There isn't any negative trends here, but there really is no difference between any of these endpoints so early. And remember that at 333 patients, the trial isn't really powered for these endpoints. So we really need to have many more events to try and see a positive trend. Next slide. So I have a summary here of the discordant data we've seen in the neoadjuvant setting using checkpoint inhibitors. And I think this is really helpful to try and understand the trials that we have. First, I think it's important to look at the largest trial, so Keynote 522, which used pembrolizumab and Impassion 31. Both of these trials showed that adding the checkpoint inhibitor to standard taxane anthracycline-based neoadjuvant chemotherapy for triple-negative breast cancer showed an improvement in pathologic complete response. We know that pathologic complete response actually correlates very nicely, particularly for triple-negative breast cancer, for event-free survival and in some settings for overall survival. The Keynote 522 and Impassion 31 trials used a different taxane backbone, paclitaxel and carboplatin, and nab-paclitaxel. But since both of these comparisons improve pathologic PCR compared to a standard paclitaxel backbone, I think that it's reasonable both of these were improved over our baseline, which I think is very nice. The other thing that's important is they included higher stage patients. Patients had to be stage 2 or 3. So what is the difference between the trials that were negative? Well, I-SPY was a small phase 2 trial, but did show a benefit in PCR in patients with triple-negative breast cancer, also an anthracycline, no carboplatin. For NeoTrip, the trial did not include an anthracycline, and based on preclinical data and other biomarker data that was actually fascinating presented from the NeoTrip trial at ESMO this year, it does appear that anthracyclines may be important in seeing the beneficial impact of checkpoint inhibitors in the neoadjuvant setting for triple-negative breast cancer. So that could explain why we didn't see an improvement in PCR in NeoTrip. And I would encourage you to look online at ESMO at the interesting biomarker data that I discussed in a mini oral on-demand session. For GEPAR-Nuevo, the trial included many patients who had stage 1 disease. And in Keynote 522, they were able to look at the differential benefit of checkpoint inhibitors in node-positive versus node-negative disease. And it did appear that the benefit was greater in node-positive disease. So I think that having a large number of patients with a small trial, only 174 patients who had stage 1 disease, explained why GEPAR-Nuevo, which added a different checkpoint inhibitor, may not have seen an improvement in PCR. We know that other variables may play a role, and we'll see more of this, the dynamics of change of TILs and PD-L1 with checkpoint inhibitors and chemotherapy. In NeoTrip, actually just the chemotherapy itself appeared to increase the expression of PD-L1, which I think is very exciting because that's why we're giving the chemotherapy with the checkpoint inhibitor to start with. And then the other thing that I think is really important about these trials is that PD-L1 status in the tumor and immune cells did not matter when the immune system is intact. So in none of these trials, we saw a differential benefit, while PD-L1 status, a striking difference to what we saw in Impassion 130. The suggestion here is that, one, you have patients who are naive to therapy, so their immune system is intact. But more importantly, as the tumor progresses, it also downregulates PD-L1 and has multiple other mechanisms of escaping the beneficial effects of chemotherapy. So it's clear that we need to start early in the treatment of triple-negative breast cancer. I think we need to be using anthracyclines as our backbone in the majority of patients. And then as we move forward, we need to understand which patients patients may not need actually immunotherapy. There was an interesting study in young women that looked at a registry and showed that young women who had very high TILs in their tumors and had no chemotherapy had a very good outcome, even with early stage triple negative breast cancer, generally very low stage disease node negative. So interesting. Next slide. Now, we can explain actually the neoadjuvant therapy in triple negative breast cancer and show you the discordance and how we might explain it. And I think that where we are right now is this is really exciting data. The FDA will review the results from both of these trials, 522 and Impassion 31, to decide whether or not PCR as an endpoint is sufficient to approve the use of checkpoint inhibitors in early stage triple negative breast cancer. But it gives us a lot of hope that potentially adding these checkpoint inhibitors might help the patients who have the very resistant disease up front. We need more data, and importantly, I think in the long term, we need the disease-free survival data in these patients in Keynote 522, which we hope to see in the next year. Next slide. Now, instead, we actually had a confusing set of data in the metastatic setting. Impassion 130 led to approval of atezolizumab as treatment in combination with nab-paclitaxel for patients with triple negative breast cancer that's PD-L1 positive. The PD-L1, again, involves immune cells, and it's only 1% or greater. We have yet to see any differential benefit based on the percentage of cells that are positive. Patients had to be at least a year from their neoadjuvant or adjuvant taxane or any chemotherapy in order to be eligible for Impassion 130 that included a placebo arm with the nab-paclitaxel. The dose of nab-paclitaxel was 100 milligrams per meter squared. Patients in the metastatic setting don't really tolerate the 125 milligram per meter squared, as I showed in previous data published from CLGB 40502. 902 patients were randomized, and the co-primary endpoints were progression-free survival and overall survival that were hierarchically tested in the intent to treat and PD-L1 IC immune cell positive populations using SP142 as the antibody. Next slide. This shows you the updated data presented at ESMO this year. Overall survival in the PD-L1 IC positive population, as you can see, had a hazard ratio of 0.67 and a p-value, as you may notice here, is not shown. Now, the hazard ratios do not cross 1, so this is a significant difference, but because of the hierarchical testing, the way the study was designed, you had to see a significant difference in overall survival in the intent to treat population to look at p-values in the PD-L1 IC population. This unfortunately was just the wrong hypothesis to start with, but based on this data, atezolizumab did have accelerated approval pending the final overall survival data. What you can see here now is that there's a 7.5-month difference in overall survival. So that's what we really want to see. Now, we started out with a 7-month difference when we had enough overall survival events. With longer follow-up now, with most of the events reported, you can see that 120 and out of 185 patients you can see that the difference actually is wider at 7.5 months at the median. So that's very encouraging. The 3-year overall survival, and 3 years very important in this population, is 22% versus 36%. But there's no difference in patients if you look at all patients, regardless of PD-L1 status. Next slide. So at ESMO, we also saw the data from Impassion 131 for the first time. We had already known from a press release that this was a negative trial, and we knew from an alert from the FDA that there was concern that actually overall survival might be worse in the patients treated with atezolizumab. We had encouraging, I think, data that it's not worse that was presented at ESMO, but we did see negative results. So patients received paclitaxel as their backbone chemotherapy. Otherwise, there was really no difference in terms of the eligibility compared to patients who were enrolled in Impassion 130. And then the other thing is that PD-L1 was also assessed with a primary endpoint of progression-free survival by investigators rather than blinded central review. The same secondary endpoints, but no attachment to overall survival here, like there was in Impassion 130. Next slide. Here you can see the primary analysis of progression-free survival in the intent to treat on the right and the PD-L1 positive population on the left. You can see that there's absolutely no difference if the primary endpoint was PFS, and so you looked at p-values in the PD-L1 positive population rather than intent to treat. Events were in 61% of patients as of the data cutoff. You can see the p-value is 0.2, and there's absolutely no numerical difference in PFS at 5.7 versus 6 months. If you think back to the Impassion 130 trial with the progression-free survival, actually this PFS is similar to what we saw in the control arm. Next slide. So this shows you the overall survival analysis from Impassion 131. The first interim analysis where you can see the hazard ratio of 1.55 led to that alert from the FDA where there were actually more events in terms of deaths in the atezolizumab arm versus placebo. And that's on the left-hand side in the PD-L1 positive population on this slide. The second interim overall survival analysis, however, was much more encouraging. That shows many more events. The cutoff is August of 2020. You can see that although there are still more deaths, this was a 2-to-1 randomization. The median overall survival is relatively similar. The hazard ratio now, the confidence intervals cross 1, and it's 1.12. Now, the 2-year overall survival rate was also looked at, which is important. These analyses are very important when you're looking at, as I showed you in Impassion 130, it's about 50% for both groups. So I don't think that we can conclude that atezolizumab results in a worse outcome, but it certainly didn't improve outcome. The median overall survival is important to keep in mind here for the patients in the group who received the placebo, and that's 28 months. So look across the overall survival on the bottom half, the second interim overall survival. It's 22 months, 20 months, 23 months, and then 28 months. So, and it's a small number of patients. If you look at the top, it's 100 patients versus almost 200 patients, 2-to-1 randomization. So what does this mean? Well, what's interesting is I think there was some marker that we don't know how to measure in this first-line population that led to a much better outcome in the placebo group than we've seen in any other trial. Great for the placebo group, but it definitely messed up the results of this study. Next slide. So one other study we need to think about, and that's KEYNOTE-355, and Javier Cortez presented this at ASCO this year, but I think it's important to show just for comparison. They actually started out thinking that they would use a PD-L1 score of 1 using this CPS scoring that looks at tumor cells and immune cell PD-L1 expression using a different antibody 22C3 and creates a ratio. So these patients could be randomized if they had recurred 6 months or greater, so at least 6 months after their adjuvant or neoadjuvant chemo, so a higher risk group of patients. Again, randomization of 2-to-1, and they showed an improvement in PFS, but not in the CPS score of 1 or greater. They revised their study while it was still unblinded after the results of Impassion 130 and after their results from another trial looking at single agent Pembro, KEYNOTE-119. So that they used a CPS score of 10 or greater. 38% of patients were positive compared to 41% of patients in Impassion 130. So without a direct comparison, we believe this may look at a similar population of patients. The PFS was significantly longer, 5.6 versus 9.7 months, a difference of 4 months, which is the greatest seen in this population and a higher risk population as well. So that would lead us to believe that checkpoint inhibitors are really important. The backbone chemotherapy included nab-paclitaxel, similar to Impassion 130, paclitaxel in Impassion 131, and then gemcitabine and carboplatin. Now, the gemcitabine and carboplatin group of patients was a smaller number. Presumably, these were patients who relapsed early. Next slide. In the forest plot for KEYNOTE-355 that was presented at the time of the presentation, you can see that patients who had de novo, if you look at the bottom of this, actually forest plot, de novo metastatic disease and a relapse at 12 months or greater, patients seem to do better. And they seem to do better if they received a taxane, which is really interesting compared to gem-carbo. Again, these are subset analyses, but it's quite interesting thinking about the comparison. Next slide. So what is our hypothesis? Why did we see a negative trial? Well, we're going to see, I think in the very near future, a breakdown in KEYNOTE-355 about how many patients received paclitaxel and what the outcome was in that group of patients. Regardless, patients received steroids in KEYNOTE-355. They received paclitaxel. The steroids were used with gemcitabine and carboplatin as well for nausea. So I don't know that it's steroids, and I don't know that it's paclitaxel either. I think there may be variation in the patient population in de novo disease, only 100 patients in the placebo group, that led to a much better outcome. And we don't really understand yet why there is a difference, but maybe it's an accumulation of all of these factors. Regardless, the 130 results remain significant with an overall survival benefit, and nab-paclitaxel remains a standard partner with atezolizumab in patients who have IC PD-L1 positive disease in the metastatic setting. Next slide. So then we saw very exciting data from the ASCENT trial. The sacituzumab govitecan is an antibody drug conjugate, a novel antibody drug conjugate in the era of time where we're seeing really remarkable results from these novel chemotherapy agents. So this drug actually is an antibody to TROP2. Who ever thought about TROP2? TROP2 seems to be a target that's actually expressed on many different cancers, not just triple-negative breast cancer, which was the focus of this trial, but actually on hormone receptor positive disease, HER2 positive disease, and on many other cancers where we've seen intriguing data as well. So quite a nice target, and it doesn't appear to be a big expression issue in normal tissue, which is key for an ADC. The other thing that's important as an ADC is the toxin. And we've seen this actually where we're looking at concerns about interstitial lung disease or pneumonitis, where a drug might cause pneumonitis or it might cause other toxicities, and we're monitoring these low risk toxicities that we think are related to the toxin. In this case, the toxin is reasonably well known. It's the most active metabolite of irinotecan, SN38, that's attached to the ADC. The other thing that's important is that the new generation of ADCs have a higher drug to antibody ratio than the earlier generation, like trastuzumab emtansine, known as TDM1. There are more like 7 to 8 drugs per antibody versus 3 to 4. So sacituzumab is given also in a unique dosing schedule. So you give it day 1 and day 8 every 21 days, as opposed to once every 3 weeks. Patients who had metastatic triple-negative breast cancer, defined by the ASCO-CAP guidelines, who had received 2 or more chemotherapies for advanced disease with no upper limit, were randomized to 1-to-1 to receive sacituzumab versus treatment of physician choice. Treatment of physician choice included eribulin, which the majority of patients received, about 50%, as well as other standard chemotherapy agents, but not taxane, since these patients had all received prior taxanes. The primary endpoint was PFS, the PFS in the primary endpoint was patients who didn't have brain metastases. The trial was actually limited to include 15% of patients with brain metastases. They had to be stable at responding. Only 13% were enrolled. A secondary endpoint is PFS in the full population that will be presented in the near future. A secondary endpoint also included overall survival and response, as well as safety. Next slide. About 530 patients were randomized, and here you can see the remarkable progression-free survival benefit with standard chemotherapy only 1.7 months, a PFS versus 5.6 months in the patients receiving sacituzumab, a hazard ratio of 0.41, representing almost a 60% relative improvement and highly statistically significant. The other thing that I think that's important is you see that the curves are together right in the beginning, but then they separate, and they remain separated out well past the median follow-up. Next slide. And then, of course, the overall survival data, again, statistically significant difference was almost a doubling in the median overall survival from 6.7 to 12.1 months, a hazard ratio of 0.58, a relative improvement of 52%, highly significant. And the curves, although they're together early on, representing early failure, maybe in brain and other areas, although we don't yet know the brain mets population outcome, the curves are then separated throughout, suggesting that these patients not only, remember the median PFS is over 12 months, that they actually do live longer because they have access to this agent. Next slide. We know that based on the data from a phase 2 trial that sacituzumab govitecan received accelerated approval for treatment of metastatic heavily pretreated triple-negative breast cancer, and we expect that and hope that this data will lead to final approval of sacituzumab in these patients. The most common toxicities are important to note. Neutropenia was the most common toxicity, 63 versus 40%, and more patients received growth factor, 49% versus 23%. The rate of febrile neutropenia was actually low, and very few patients discontinued treatment due to toxicity. As you can see here, 4.7% versus 5.4%. Even dose reductions were similar to the treatment of physician choice. Diarrhea was also seen. All grade diarrhea was much more common with sacituzumab, but only 10% was grade 3. So that's encouraging, and patients can be educated about how to manage the diarrhea. Alopecia is seen, as well as fatigue. But overall, I've given the drug quite a lot, and I think that it's quite well tolerated. It's a new standard of care for metastatic triple-negative breast cancer. The toxicity is predictable and manageable. There's an ongoing TROPiCS-2 trial in hormone receptor-positive metastatic breast cancer that we're looking forward to seeing results from. I think this is very exciting to be able to expand the use of this drug to other subsets of metastatic disease. There's also an interesting antibody drug conjugate that's worthwhile mentioning in this setting, trastuzumab deruxtecan, that has accelerated approval for patients who have pre-treated HER2-positive metastatic breast cancer based on a single-arm trial that showed remarkable response as well as progression-free survival. There's a lot of interest actually in how this will work in patients who have HER2 low disease, 1+ or 2+ by immunohistochemistry with no evidence of amplification of HER2 by FISH testing. This trial that's looking at trastuzumab deruxtecan versus treatment of physician choice in patients who have had received 1 to 2 lines of prior chemotherapy for metastatic breast cancer, largely a hormone receptor positive population, is ongoing, and we look forward to seeing those results in the future as well. So an exciting era, and I think now we're looking to move sacituzumab earlier in the treatment of triple-negative breast cancer. There's an exciting trial planned by the German Breast Group that will look at giving sacituzumab post-neoadjuvant therapy for both triple-negative and hormone receptor-positive breast cancer in patients who have residual disease. Next slide. So now I think one of the big splashes, other than the trials that I just showed you about, was whether or not we're going to change our treatment for patients who have early stage high risk hormone receptor positive breast cancer by adding CDK4/6 inhibitors. We know that CDK4/6 inhibitors are highly active in patients with metastatic hormone receptor positive breast cancer. We've seen survival benefits in the second line setting in combination with fulvestrant, and also in the first line setting, particularly in our highest risk group of patients who are pre and or perimenopausal at the diagnosis of metastatic disease. In those patients in the first line setting, we have the only trial to date that's shown an improvement in overall survival with the addition of the CDK4/6 inhibitor ribociclib. So based on this very exciting data with dramatic improvements in progression-free survival in patients staying on drug that was reasonably well tolerated compared to any other targeted agent we have, we are very excited about trying to improve outcome in patients who have high-risk early-stage disease. It's important to keep in mind how you would design these trials. So you're thinking about patients who have hormone receptor positive disease. We know that the recurrence risk goes out out to 20 years, and 50% of the recurrence risk in high-risk patients can be after 5 years. So if you're going to do a trial like this, you actually want to enroll a group of patients who have the highest risk in the first 5 years. Otherwise, we're all going to be, long gone before we see a result of this treatment. Also, if you're only going to give the treatment for 2 years, which both of the trials that have results did, you definitely want to have a group of patients who relapse early. So the trials, PALLAS and MONARCH-E, were presented with palbociclib and abemaciclib, but they used different patient groups in order to understand risk and enhance the risk of recurrence in the first, say, 3 years. So the PALLAS trial actually enrolled patients who had stage 2 to 3 hormone receptor positive HER2 negative breast cancer, enrolling 5,600 patients, and they capped the number of patients who had stage 2A disease, so T2N0 disease. Patients were enrolled and they had to be enrolled within 6 months of starting their adjuvant endocrine treatment and within 12 months of diagnosis. They were randomized to receive the palbociclib or not, no placebo, and standard endocrine treatment with ovarian suppression if they were premenopausal. The primary endpoint was IDFS. Next slide. PALLAS included a group of patients who had stage 2B disease. About 33% of the patients and about 49% of the patients had stage 3 disease. About 82% to 83% had prior chemotherapy, I think going along with the relatively lower risk group of patients compared to MONARCH-E. Next slide. So this shows you the IDFS and the distant recurrence-free survival. There was absolutely no difference between either endpoint. As you can see, about 88 to 88.5% for IDFS, and for distant recurrence-free survival, about 90%. Absolutely no difference, as you can see here, and in subset, no difference as well. The median follow-up here is 24 months, so the majority of patients had completed their 2 years of therapy. Next slide. If you look at the pre-specified subgroups, including clinical risk, based on their determination of clinical risk, there was also no difference shown in the red box in the lower part of this slide. Next slide. So Monarch E actually was a trial that also used 2 years of a checkpoint inhibitor, and the checkpoint inhibitor here is abemaciclib. Abemaciclib is given continuously compared to palbociclib and ribociclib, which are given on a 3-week on, 1-week off basis. Patients were randomized who had high risk, defined as either 4 or more axillary nodes, so stage 3 disease, but a defined stage 3 subgroup, or 1 to 3 positive axillary nodes, and at least one of the below, tumor size of 5 centimeters or greater, grade 3, or centrally tested Ki-67 of 20% or greater. Patients could be enrolled actually in a relatively shorter time period from starting their adjuvant, their endocrine therapy, so compared to PALLAS. So they may have captured patients a little bit earlier. Endocrine therapy versus endocrine therapy and abemaciclib, and the endocrine therapy of physician choice. Next slide. This slide did show a significant difference in invasive disease-free survival, shown in the larger curve here, reducing the risk of invasive disease by a relative 25% with a hazard ratio of 0.747 and a p-value that was highly statistically significant. The absolute difference in the median IDFS was 3.5%, 89% versus 92.2%. The small inset curve actually cuts the IDFS at the 70%, so it's important to keep in mind when you're looking at that. And it just shows you the difference at 24 months and showing the separation of curves in patients who didn't have sort of cryptic metastatic disease and who relapsed very early for that. And this is really important. Now, only 12.5% of patients have completed 2 years of therapy, so it will be interesting to see what happens over time as more patients are exposed to 2 years of treatment. Next slide. This shows you the group breakdown based on the risk group, and you can see here 60% of patients, and I'll show you this in a separate table in a moment, 60% of patients had 4 or more positive nodes, so it's definitely a higher risk group of patients. 40% had 1 to 3 positive nodes, and the additional high risk eligibility criteria is listed on the right-hand side with Ki-67 of greater than 20% only, was only in about 8% of patients, grade 3 in about 20 to 22%, and the tumor size 5 centimeters or greater in about 15%. Next slide. So this shows you the distant recurrence-free survival, also very, very encouraging. So here you can see the hazard ratio of 0.717 for distant recurrence-free survival, highly statistically significant, and a difference in absolute number of distant recurrence-free events. The greatest reduction was to liver and bone, and I think the liver is really encouraging because bone is the most common site we see in general, but in the group of patients who have very high-risk disease, higher Ki-67, higher burden of disease, visceral disease is also not infrequent. The absolute difference in DRFS was 3.3%. And you can see the forest plot showing that basically most patients benefited significantly. The only group that actually, there's a tiny group of patients with grade 1 disease. And for that, there's a high confidence interval and tiny numbers. It's hard to say anything, but if anything, they didn't benefit as much as the patients with higher risk disease. The same is true for patients 65 years or older. Again, a very small number, a group of patients compared to the overall population, but about 400. And in that group of patients, they're probably more likely to have indolent disease. The way Monarch E was designed was based on data from a number of trials, including trials from the HICAM group in Spain, where they actually showed that the early relapse was increased in patients who had 4 or more positive nodes. And in 1 to 3 positive nodes, you had to have additional risk criteria. So I think that they designed the trial very, very well for a high risk group. Next slide. And the side effects, of course, are important because we see this as potentially practice changing in the near future. More common diarrhea, although the grade 3 diarrhea rate was relatively low. Fatigue, there was more neutropenia, as you would expect as well, and some GI-related toxicity such as abdominal pain and nausea. Interestingly, there was a little higher rate of venous thromboembolism and pulmonary embolisms and interstitial lung disease, as has been described in the past. These numbers are very, very small. ILD has to be monitored for. And for venous thromboembolism, I suspect that this was mostly in patients taking tamoxifen, but we'll see that in a future update, hopefully at San Antonio. Next slide. And then I've just compared to you these differences here, showing the similar number of patients, the eligibility, higher risk group in Monarch E, the median follow-up much shorter in Monarch E at 15.5 months, but the very big difference in the node positivity, and then the grade 3, where you see higher grade 3 in Monarch E, Ki-67 wasn't reported in PALLAS. Most patients received AIs. Next slide. So the treatment discontinuation, I think, is important when we're thinking about benefit, not just risk. In the palbociclib group, a large number of patients discontinued, and mostly due to adverse events. 64% of patients stopped early. Actually, 42% of patients stopped early, and 64% of those stopped early due to adverse events, mostly neutropenia. That was protocol mandated. This increased over time so that the actual exposure to the drug was significantly lower. The early discontinuation rate for Monarch E, again, very small number of patients at 2 years, but it was very small, so actually only 16.6%. So this may also make a difference. You need to have high risk and you need to receive the drug. Next slide. So in summary, Monarch E, I think, has the potential to change the standard of care. We need a little bit longer follow-up and more patients completing study treatment, but we expect to see this in the near future, hopefully at San Antonio. We're looking forward to the overall survival data as well, which I think will be excited, but will take quite a long time. A low rate of discontinuations due to adverse events. I'm guessing we probably shouldn't give this with tamoxifen due to the rate of venous thromboembolism, or we should give prophylaxis. For PALLAS, again, we just don't know. And I will quote George Sledge, who gave an excellent discussion for this plenary talk. It's a certainty that one cannot benefit from a drug one does not take. The optimal duration of therapy is still being evaluated in the ongoing NATALIE trial that just increased the number of patients with stage 3 disease based on an amendment because of the data that I just showed you. In that study, ribociclib is being given for 3 years. Thank you very much. Next slide.
Okay, we actually have lots of questions, and because of the time, we're going to limit it to one, but perhaps we can answer those separately through the chat mechanism. And we'll focus on the question, because of Monarch E, well, I shouldn't say that. Should we think about using sacituzumab in second line, even though the approval is in third line?
Well, the ASCENT trial actually gave sacituzumab in patients in the second line if they relapsed within a year of their adjuvant or neoadjuvant therapy. So I think we do have a group of patients who we consider second line, but have relapsed within a year who would be eligible. I do think I would consider sacituzumab in the second line. I think patients who relapse early, who get a taxane, who, with or without immunotherapy, they might get gem carbo next, but then you end up with low platelets and a lot of issues. So being able to give sacituzumab might be easier. And then in patients who relapse early, who are not candidates for checkpoint inhibitor therapy, they're getting gem carbo first line, or at least a combination like that, maybe eribulin. And then I think sacituzumab is a very good choice of treatment in the second line setting.
Okay. Again, we'll answer those other questions separately, but because of time constraints, we'll go on to gynecologic tumors. Next slide. So I'm going to caution you that we all know that the ESMO in 2019 was record-setting for gynecologic cancers. We had 3 plenary presentations, randomized phase 3 trials. All 3 were positive, all 3 published in New England Journal, and 2 of them led to FDA approvals. So this was a bit of a step down, but nevertheless, there's some important trials I think we should at least talk about. And the first one, the top one, was Imagine 50. The schema here demonstrates this. This we already knew based on the company releases. This was a negative trial, but it was a very large phase 3 trial of bevacizumab containing therapy with atezolizumab in newly diagnosed stage 3 and 4 ovarian cancer. The eligibility is seen on the left. The only point to be made is that it included both neoadjuvant and patients who had gone through surgery, postoperative stage 3 with macroscopic residual disease. Stratification factors were predictable. I will point out that PD-L1 status was one of them, including immune cells less than 1% positive versus greater than 1%. The schema is shown there. They received Bev in both arms and Tesla at 1,200 milligrams every 3 weeks. And the endpoints included co-primary endpoints, PFS in the intent to treat, and also PD-L1 positivity. So the significant factor had to be less than 0.002 to be considered positive, and also OS. Next slide. Don't need to be a statistician to tell you this is a negative trial. It was exceedingly well conducted. If you look in the intent to treat population, the median PFS was 18.4 versus 19.5, hazard ratio of 0.92 and not significant. In the PD-L1 population, the curves begin to separate a tad, and the median PFSs are 18.5 versus 20.8. Again, hazard ratio of 0.8, but the p-value of 0.03 was not considered to be significant. Next slide. And as you could imagine, the OS analysis is very early and not significant. You can see the curves in this slide. Next slide. Subset analysis, I guess when you have a negative trial, you begin to try to hang on to things. So the subset analysis actually generate the most interest, and you see the boxes there. There was considerable discussion about clear cell as a subgroup where the hazard ratio is 0.64, although it overlaps 1, but these patients seem to be getting a benefit. Clear cell cancers of the ovary, as you know, is a difficult tumor to treat. And there are other trials, which I can't go into now, but you probably are familiar with them, that suggested clear cells may respond to immunotherapy. So this was interesting. And then a ad hoc analysis of the PD-L1 status suggested that the really high expressors for immune cells greater than 5% perhaps benefited from the presence of atezolizumab. But the take-home message of this trial, I think, is a couple of important messages. First of all, when we move new therapies like IOs up quickly without really understanding the biology, we tend to get into trouble. This trial reinforces what was seen in Javelin 100, which used avelumab. And in that particular trial, very large, randomized phase 3 trial, again was negative. In fact, those patients receiving avelumab seemed to actually do worse. So we need to understand the biology better. Second take-home message is we don't really have a biomarker to identify those patients who really benefit, and a considerable discussion about this PD-L1 staining and whether that's relevant. This is all important because there are ongoing trials, including Athena and Duo, that have incorporated IOs in the upfront treatment of ovarian cancer. And the question is, should we somehow, if we can, get the right biomarker to analyze those trials? They're still ongoing, so there's a lot of debate about this. But the take-home message right now, no role for IOs in ovarian cancer. Next slide. Now, the best data, I think, that was presented is the follow-up, 5-year follow-up from SOLO-1. As you know, SOLO-1 was a trial that tested the upfront use of olaparib in maintenance in patients with newly diagnosed BRCA mutated ovarian cancers. This included both germline and somatic. That trial showed a dramatic effect of olaparib maintenance, and you can see the primary analysis in the upper right-hand corner of the slide, which showed the median PFS at that time had not even been reached for olaparib, and it was 13.8 months with placebo. This led on to very rapid approval by the FDA for olaparib in BRCA mutated, newly diagnosed ovarian cancer, whether it would be germline or somatic. Next slide. This is the 5-year follow-up, so we really all wanted to see whether that impact would be sustained. And the take-home message is, yes, it is. So the PFS 5-year follow-up is shown there. We now have a median PFS on the olaparib arm of 56 months compared to 13.8 months. This is a very effective therapy. Hazard ratio of 0.33. And perhaps more importantly, down in the lower right-hand corner, you'll see that there was no additional cases of MDS or AML reported with this long follow-up. So not only is it effective, so far the safety signals are remaining unchanged, and the drug is very well tolerated. We also have PFS2 on time to second therapies listed in the lower left-hand corner. And the bottom line is that this benefit from olaparib is being maintained throughout the treatment and management of these patients. I will also point out some interesting aspects of that curve. If you look at the 2-year treatment cap and then go to potentially 48 months or even 60 months, the curve is dropping down. It's raising the question as to whether patients would benefit more if they continued on olaparib. And so I think there'll be more discussion about that. Next slide. So we'll go from ovary, those are 2 significant presentations in ovary, to cervix. As you know, pembrolizumab is approved for cervical cancer. It has a 12% response rate, but a 14% response rate in the PD-L1 positive subgroup. The real question in our mind is why, for a tumor that has a viral antigen, is a viral-driven tumor, the response rates aren't even higher. And so this is a trial. These are actually 2 different phase 2, independent phase 2 trials, looking at a combination of an anti-PD-1 in combination with an anti-CTLA-4 antibody. And these are from Agenus, the company Agenus. This is, the combination has been given fast track approval. And you can see in the box, the single agent versus the combination, and the dosing and imaging every 6 weeks. Next slide. Take home message here is to look at the objective response rate. And it is very encouraging in a sense that you have about a 14 or 13% response rate with the anti-PD-1 by itself. That is in the same range as what we see with pembrolizumab, but the combination essentially doubles that. Is it synergistic versus additive? We could argue about that, but the point is, this is a very, very poor prognostic group of patients, and the response rates are considerably higher with the combination. The duration of response is even more impressive, 15.4 months in the single agent anti-PD-1. The combination has not been reached. It looks like it's somewhat preferential for squamous cell as opposed to adeno. That may be consistent with the fact that adeno or adenosquamous tend to do poorer, and 2, they may not be as high of a rate of HPV infection as squamous cell. Next slide. This is the waterfalls plots, and again, it just reinforces what I just said. There is I think if you step back and look at it, it doesn't look like PD-L1 status is that great of a biomarker, but in fact, if you look at the response rates in the box, depending upon PD-L1 expression, there certainly is an increased response rate in those tumors expressing PD-L1. Next slide. Nothing comes without some risks. So if you look at the right-hand side of this, this is looking at safety. The combination essentially doubles the incidence of GI abnormalities, laboratory abnormalities, and endocrine disorders. I will point out, though, for these immune therapy SAEs, most of it is low grade. The grade 3 or higher listed there is about the same for the single agent versus the combination. So that's encouraging. My guess is, and the take-home message is that this combination, given the poor prognosis of this patient population, how we desperately need to improve response rates, particularly immune response rates, that this combination will have legs, and you'll see more about it. Next slide. Okay, while that's being developed, I have to bring to your attention Nova TV 204. This is a ADC that targets tissue factor. Tissue factor is upregulated in many, many tumors, but in particular in cervical cancer. It carries a payload and delivers it to the tumor. This trial design used a single agent and again, looked at recurrent extrapelvic metastatic cervical cancer. They had to have had a doublet chemotherapy, which is generally GOG 240, which uses bevacizumab. So again, this is post GOG 240, a very poor prognostic group of patients. Next slide. And you can see here, looking at the left-hand side, I would look at both CR and PR rate. You almost never see CRs with any chemotherapy in this patient population. You have about a 7% CR rate, a 17% PR rate, and a stabilization of disease of about 49. So disease control here, which is important for these patients, is actually quite high. The median duration of treatment, 8.3 months. Again, I think quite astonishing. This agent is on fast track. The confirmatory phase 3 is already designed and will overlap the completion of this trial. So this is a antibody drug conjugate you should keep your eye on. It is likely has legs and will go to approval. Next slide. Nothing happens without, again, some risk and some safety issues. There was great concern about the ocular toxicity of this. This is not like other ADCs that give you keratitis. It gives you a conjunctivitis. And you can see on the left-hand side that most of it is low grade. It is not without some problems, but can be managed with lubricating eye drops and steroid eye drops. The center bar looks at bleeding events with this ADC. Remember, I said it targets tissue factor. Tissue factor is within the coagulation cascade, and so you would expect some bleeding. This also is low grade and manageable. I will point out the epistaxis can be a little bit scary for patients, but can be controlled. They need to be counseled on it. And then the rest of the safety profile, I think, is very acceptable. Next slide. I just want to bring your attention, since we're on ADCs, that there was a presentation of Mersana's antibody drug conjugate XMT-1536. This is an interesting ADC, I think, because first of all, it targets NaPi2b. NaPi2b is known to be a target in ovarian cancer. It's upregulated. There has been previous studies with other ADCs that unfortunately did not have a significant response rate. I think this ADC is better partly because of the technology. You see this schema there. They use a polymer, which allows them to provide a lot more payload for each antibody, and they can even define the amount of payload per antibody, which helps its safety profile. So if you look in the bottom table, the response rates adding CR, PR, and stable CR and PR is about 35% for the high NaPi2b expressors. If you look at the disease control rate, it's as high as 85%. And these are in platinum-resistant ovarian cancer patients, not an easy patient population to manage. So we're very encouraged by this. This is going to go on to a randomized phase 3 trial, and the issue becomes, how do you define high and how do you define low? Because ADCs are completely dependent upon their target and the biomarker to select patients. Next slide. And I think I'm finishing up. I bring this new agent to your attention. This is a phase 1b/2 of ribociclib and weekly Taxol in advanced or metastatic platinum-resistant ovarian cancer. This had multiple cohorts. We actually had the trial open. I treated a number of patients with this. It's an interesting agent because TIE2 is the receptor for the angiopoietin ligands. Angiopoietin ligands, agents targeting them have been disappointing in ovarian cancer. All the trials have been negative, but this actually looks at the receptor, and the receptor is not only on, it affects angiogenesis and lymph glands, but it also affects macrophage function. So it really has a very different targeting, very different mechanism. And you can see here, this was 2 doses of paclitaxel in combination with the agent. Cohort 3 was ovarian cancer. Next slide. Some early data here for heavily pretreated platinum-resistant ovarian cancer patients shows a partial response rate of about almost 40% with a stable disease of 50. So the disease control rate, clinical benefit rate here is pushing towards 90%, and generally speaking, well tolerated. So I think this combination in this agent is interesting. You'll hear more about that. Next slide. And that summarizes what was interesting, in my opinion, for gynecologic cancers at ESMO. Thank you.
Thanks very much. That was great and so interesting and exciting to see all the, I think, updated data and also emerging results. I think we have time to go back and forth for a few different questions here. And I think one of the questions that came up was whether or not PARP inhibitors should be limited to HRD positive patients and what the role of HRD testing is in first-line ovarian cancer.
Well, if we have about 7 hours, I can explain that. It's a very hot topic. So as you know, Apollo 1 was in the New England Journal and then led to the approval of combination olaparib and bevacizumab, but it was only in the HRD population. So there's an FDA recommendation out there now for newly diagnosed ovarian cancer that does incorporate HRD testing. So where does that leave us? I'm still a sequencer. I think there's a lot of sequencers out there. So we're doing germline somatic panel testing to look at actual genes. I have a lot of colleagues who will go straight to HRD. My only plea, if you do HRD on the tumor and it's positive, you're obligated to go do sequencing to make sure you know your lady doesn't have germline mutations that she's passing on and needs genetic counseling. So HRD, to summarize it, HRD is here, I think. It's not a great biomarker, but it's not bad. It's perfectly reasonable to do it. If you do it, then you need to do and it's positive, you need to do the sequencing later on. I go the opposite direction, sequencing first, and then if I want to do the HRD, I do it later.
Yeah, that's what we do in breast cancer too. Just a similar question that came up for breast cancer was how one would sequence sacituzumab with PARP inhibitors. And we don't have survival benefit of PARP inhibitors in breast cancer. Interestingly, a much more resistant population overall for PARP inhibition compared to ovarian cancer without the clear benefit yet in HRD alone. But I think that generally, if a patient had triple negative, BRCA positive disease, BRCA-associated disease, I probably would give PARP inhibitors before sacituzumab unless they have really extensive visceral disease and need sort of a more emergent treatment, simply because it's just better tolerated. And I would generally give that in the first or second line setting, depending on their use of checkpoint inhibitors. So I think that it really has to be individualized for the individual patient. Some of it depends on whether they have more platinum resistant disease or not.
And I think you're absolutely right. The biology here is actually quite interesting. Because I think the poster child for PARP inhibitors really is ovarian cancer. If you look at TCGA, there was sort of that argument like, triple negative really looks a lot like ovary, but there are substantial differences. And I think you're emphasizing that. So it really needs to be individualized.
Yeah, it's interesting. And for most patients, PARP inhibitors are very well tolerated, but there's a subgroup who have a lot of toxicity. And so we have to watch out for those patients too. Another interesting question that came up was what kind of patients would be best treated with tisotumab vedotin compared to IO type therapy? Yeah,
it's a great question. Of course, the ADC is not approved yet, so we don't need to make that decision, but I think it's the forward-thinking question. My guess would be if you're PD-L1 positive, given the duration of benefit that patients get from Pembro, that I would use that agent first and then follow with the ADC if they should progress. And if they're PD-L1 negative, this is going to be the issue, because PD-L1 is not a great biomarker in my view for cervical cancer, but if they're negative, do you go straight to the ADC? I think that would probably be reasonable, but I'll wait. I'm going to wait to get a little more substantial data with the ADC. And that'll come with the randomized phase 3.
Yeah, it's interesting. Another question that came up for the breast cancer side was whether we would give checkpoint inhibitors to node-negative patients when we're giving neoadjuvant therapy for triple-negative breast cancer, and whether we should give checkpoint inhibitors to all patients who have stage 2 and 3 disease. Well, first of all, we don't have approval for checkpoint inhibitors in the neoadjuvant setting. I think we do have a tendency, just in terms of my chats and talking to people, in giving checkpoint inhibitors to patients who have sort of a poor response to our standard neoadjuvant therapy, simply because when patients develop metastatic disease, we can't rescue them. So we are using it in that situation, but I think very sparingly. We have to keep in mind the toxicity of checkpoint inhibitors. We didn't really talk about much. We didn't have time in this, and I think people are aware of it, but some people do have lifelong need for endocrine therapy or can get very, very sick from even a single dose of a checkpoint inhibitor. I have a patient in clinic now who got neoadjuvant pembrolizumab on a trial and is quite ill. Now you can rescue them with steroids, but it's important to keep in mind. So I think that I wish we had this information now, but I think that a combination of TILs and stage may help us, and maybe we'll be able to understand, the rapid responders better who respond to chemotherapy and are cured with chemo alone over time. At the moment, I think we need to wait for additional data from these trials. And of course, I think the event-free, disease-free survival data is really critical here in terms of benefiting our patients. Go ahead.
I follow up real quick. There is a comment just like that for cervical cancer. Is it worth the data we showed adding the anti-CTLA4, to an anti-PD-1? And I think it all depends upon the disease you're treating. So for cervical cancer, they have so few options and they do so poorly, I think, and it's a young population. My guess is, unless we see something different, the combination will be worth it.
Yeah, I think I agree with you. I think it's an exciting time, and it's going to be so hard to understand, because when you looked at the young population who didn't get chemo, no treatment, had stage 1 triple negative disease, the ones who had really high TILs did better, but they still had some that relapsed and died. So then you go back to HER2 and breast cancer, you're thinking maybe we could prevent it in everybody. We have to balance the risk and benefit and the cost over time. In any case, I'll turn over the podium to Anne, and thank you to Axiom for giving us the opportunity to share this really exciting data.
Agree completely. Thank you.
Yeah, thanks to both of you for taking the time to speak with us and our participants today. Just a quick reminder that our final ESMO Town Hall will be this afternoon, shortly at 12:30 Eastern, where we'll be discussing innovation and exciting results in GU tumors from prostate, bladder, and RCC. So thank you for tuning in. Hope to see you this afternoon. And above all, thank you, Dr. Rugo. Thank you, Dr. Buehrer, for being here with us today. And hopefully we can meet you in person next year in Paris.
Yes, I hope so. Thanks very much, everybody, for listening.
Stay safe. Bye-bye.